Good afternoon, everyone. Thank you so much, Jafri sir, for such nice introduction. Thank you so much, Abid bhai, Khalid bhai, for inviting me over here for such a noble cause. The RumiCare Foundation in the memory of Rizvi sir's beloved son. You know, these foundations, it's not an easy task to develop such a foundation and then to maintain it for a long time, helping the patients. This initiative has to come from inside. And he lost his son. I can feel that pain. And the reason why I'm an oncologist and I'm today here talking with you all, it's again the same story. When I was doing my MBBS, I lost my uncle for cancer pancreas. I was in second year of my MBBS, and that was the time I decided that I have to do something in this field and give it back to the society. Luckily, I got into Tata Memorial into radiation oncology. I finished that, went to Canada for super specialization, came back, and since then it was the thing from my inside that I have to give it back to the society. And my father, he wanted me to do this because he had worked hard whole of his life, and that is the reason I'm here. So he wanted me to give it back to the society. So I started an initiative since I belong from the Konkan belt. So I started cancer-free Konkan Abhiyan, where I used to go to the different colleges, schools about anti-tobacco campaign, anti-smoking, anti-alcohol campaign, making people aware about the cancer, about its early signs, how to pick up the cancer in the early stage. So many things, so that's what I said, it has to come from inside. Recently, almost 3 years back, my father got diagnosed with brain tumor, unfortunately. We did surgery, chemo, radiation. He did very well for 3 years. The tumor got recurred in February. We got him operated again, radiation again, chemo again. But somehow it was a very aggressive variant, and I lost him just last Sunday. So that, someone who wanted you to give it back to the society, you being an oncologist, you have everything under the sky you can do for your father, but still you feel so helpless. No? So I had everything, you name it, the proton therapy, the head of proton therapy is Dr. Rakesh Chilali, is my MD teacher. I had best of the medical oncologists, including Shivam and all these people. They are all colleagues. I could have done everything for my father, but something is destiny, and we cannot fight the destiny. I lost him this last Sunday only. So request all of you to pray for him, that Allah subhanahu wa ta'ala bless him with Jannatul Firdaus. So I'm here, Jafri said that called me. I was supposed to give a lecture, but since I was not prepared with my talk, he just said to give an introductory lecture. So I'm here with you all. And anyways, so I'll be briefing about the breast cancer, the evolution of breast cancer treatment in the last 3 centuries, how it had evolved over a period of time. By the way, I could see a lot of people from Tibia College here, right? Many people from Nagpara Tibia College. I had an old connection with that hospital. I used to stay in Wadi Bandar at Jafar Suleiman, Musafir Khana, and all the doctors who used to study at Tibia College, we used to stay at Jafar Suleiman. So they all were colleagues. So, and the second reason is my ससुराल is just next building to Tibia College. So उससे वो bonding थोड़ी और strong हो जाती है. वो कहते हैं ना, क्या हुस्न इत्तेफाक है कि तेरी गली में हम एक काम से गए थे और फिर काम से गए. So jokes apart. So let me talk about cancer, how it started. So it was started in 17th century When Dr. Henry Legrand, he was a French physician. He thought that breast cancer can only be treated with surgery. Those days, cancer was, the people used to feel that cancer was a deadly disease and nobody survives after the cancer. So he came up with that term that you remove the entire thing and the patient gets cured. So that was the time in 17th century. I really don't know how they used to perform the surgery, because in that century anesthesia, the antibiotics, those were not really developed at that time. So it went on for almost 2 centuries, where the people used to think that breast cancer is just a local disease. It doesn't spread to the other part of the body. So they used to remove everything. Then, so the surgery was the only available treatment till almost the 19th century. I'm talking about 200 years. The surgery was the only mainstay of the treatment for the breast cancer. It was the surgical skills, they were reformed over the period of time, and in 19th century it was William Halsted who developed the breast surgery further by doing Halsted radical mastectomy. But even in that, he used to remove the breast, he used to remove all the muscles, and patient used to have lot of pain and lot of morbidities after the surgery. In mid 19th centuries, it was Fisher who coined the term that breast cancer is not a local problem, it's a systemic problem, that it can spread to other parts of the body. That was a time, and if you decrease the estrogen supply to it, you might have regression in the tumor. That was the time people started having, they started removing the ovaries along with it, with the breast removal, and they found good results with that. But ovaries is not only the source of estrogen, it can come from a gland on your kidneys called adrenal gland. Then people started doing breast surgery, oophorectomy and adrenalectomy with that. They had good results, but the things were very clear that it's not a local disease anymore, and you need some systemic treatment in the form of either hormonal treatment and or chemotherapy. That was a time when chemotherapy was started. Again, there's a landmark trial by Fisher published in EBCT. There's EBCTCG trial. That's early breast cancer trialist group trial. So once Fisher coined that it is not anymore a local problem, why do you need to remove the entire breast? So what he did is he compared patients, 10,000 patients approximately. There were 20,000 patients, right, Shivam? Oh, it's busy in phone. So there were 20,000 patients in that trial. So 10,000 women, he did the radical mastectomy, he removed the entire breast. And in 10,000 women, he removed just the tumor, followed by radiation. And the results were striking that, whether you remove the entire breast or you remove just the tumor, the results are same. That itself says that why do you need to remove the entire breast? That was a time that term was coined, that's called BCS, that breast conservative surgery. And nowadays most of the patients, we don't need to remove the entire breast unless they have some contraindication. So this is the way the breast cancer surgery has evolved. So I'll conclude by saying just two take home messages from my talk is cancer is it in an early stage, especially for the women having more than 40 or 50 years, by doing regular mammography. So if you pick up in an early stage, you don't need to lose the breast and you can have a long survival. So that is one thing, that cancer is detected, is curable if it is detected early. And the second most important thing for the women who get breast cancer, that a part of treatment of her cancer. More than 90% of the women nowadays, we can save their breast and cure the cancer at the same time. Thank you so much. Thank you.
Thank you very educative information. Dr. Wasim for his generous speech and giving us time. Dr. Wasim, I would request with Dr. M.T. Khan, one of the renowned orthopedic surgeons in India, has been consistently helping patients and doing a lot of work. On behalf of the Help Yourself Foundation of Rizvi, we would request you to kindly accept. Thank you, sir, for removing so precious of your time and being with us on this time. We also have with flower. He is one of the best gastroenterologists, GI as we all call, known all over India again. These are few of the best ones who have come here. They are all young and they are doing wonderful things in their life. I request Sonam now to please give us a brief presentation about nutrition. Thank you very much.
Yes. Hello. Hi, good afternoon, doctors and everyone. Myself, clinical dietitian Sonam. So today we are going to talk about the benefits of diet in cancer. So let's start. To eat is necessity, but to eat is intelligently is an art, and I am that artist. So benefits of diet in cancer. So objective, discuss how nutrition can be related to the development or the prevention of cancer. Skip कीजिए. Skip. 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 Next. Describe nutrition therapies for cancer. So let's start. What is cancer? Cancer is characterized by abnormal cells growth. Cells become unstructured, excessive, can occur in any organ. Next. So why nutrition is important in cancer treatment? Healthy eating habits are very important. Slides लगाइए. Slides. Buzz. So healthy eating habits are important during and after cancer because prevention, maintain and recovery, not only calories and proteins but macro and micronutrients are very important. Macro, for example, carbs, carbohydrate, proteins and fats. Micronutrients is, for example, vitamins and minerals, calciums, iron, magnesiums, etc. So it is also help to maintain body weight, strength and decrease side effects both during and after treatment of cancer. Next. So benefits of good nutrition during cancer treatment. Keep up energy and strength in cancer, maintain weight, body store for nutrient, better tolerate treatment related to side effect, faster recoveries, lower risks for infections, prevent and muscles and bone losses क्योंकि कैंसर में मोस्ट ऑफली वीकनेस और बोन लॉसेस की प्रॉब्लम्स होती है. तो decrease side effects of cancer treatment and problem that affect nutrient. Keep up the patient's strength and energy, help the immune system fight infection, help the body recover easily and quickly, keep up improving the patient quality of life. Next. So, radiation and chemotherapy main causes xerostomia, dry mouth, dysphagia, difficulty in swallowing, anorexia, nausea and vomiting, diarrhea with patient fluent and electrolyte imbalance, radiation and chemotherapy depress appetite. Next. So, nutrition support given to the patient who is not able to take enough food by mouth by using enteral nutrition and parenteral nutrition. So, enteral nutrition is through into the tube in stomach to intestine. For example, nasogastric tube, jejunal tube. Parenteral nutrition influence into the bloodstream. For example, TPN and PPN. Next. So in this slide we are going to see the types of food can be given in tube feeding. Normally जब हम tube feeding में patient को diet देते हैं तो वो clear liquid form में ना जाए. At least try करें कि ये 6 foods भी उनमें रहे. Cereals है for example rice kanji, barley water, dalia water, oats water. पल्सेस मूंग दाल तूर दाल ट्राई करें कि अवॉइड रहे गैस फॉर्मिंग चीजें चना है छोले हैं राजमा है तो इन्हें हम मोस्टली ट्यूब फीडिंग में ना दें मिल्क एंड फ्रूट जूसेस मोस्टली डू नॉट फिल्टर एटलीस्ट थोड़ा ब्लेंडराइज फॉर्म में जाए जिससे एनर्जी है कैलोरीज सारी चीजें उनको प्रॉपरली मिल पाए वेजिटेबल जूसेस हैं वेजिटेबल सूप्स हैं नॉन वेजेस जैसे चिकन नॉर्मली चिकन ब्रॉथ एंड ब्लेंडराइज एग्स नेक्स्ट So, relationship of foods and cancer. So, certain substances in food are thought to be carcinogenic. So, nitrate in curds and smoked food associate with stomach and esophagus cancer. High fat diet associate with uterine, breast and colorectal cancer. Excessive calories intake associate with gallbladder and endometrial cancer. Alcohol, cigarette are associated with lungs, mouth and esophagus cancer. Next. So certain diets seem to have health benefit. Diet high in fiber help protect against colorectal cancer. So fibers mostly हमें soluble और insoluble दो forms के होते हैं तो solubly हमें fruits and vegetables और insolubly हमें good sources like pulses हैं cereals हैं nuts हैं उनमें बहुत अच्छे amount में हमें मिल सकते हैं for cancer patient. Diet rich in vitamin C may protect against stomach and esophagus cancer. Vitamin C are good sources of antioxidants. तो mostly अगर हम foods में देखा जाए तो हमें vitamin C like lemon है, oranges है, pineapple है, citrus fruit. तो good sources of antioxidant help to reduce the cancers. Diet high in vitamin A may protect against lungs cancer. So vitamin are similar rich in antioxidant. तो mostly हम red, yellow, orange fruit जैसे beet है, carrots हैं, green leafy vegetables हैं. तो ये भी चीजें हम कैंसर पेशेंट को दें जिससे एंटीऑक्सीडेंट्स फ्री रेडिकल्स को किल करे और उनकी बॉडी प्रिवेंट हो सके easily. So legumes, for example, vitamins, proteins, good sources. So fight against cancer. High intake of soya foods are associated with decreased breast cancer. Mostly देखा जाता है soybeans contain rich in antioxidants and anti-inflammatory. Chemically उसमें isoflavones presence होते हैं तो वो breast cancer में free radicals को kill करते हैं. तो good sources अगर fruits में देखा जाए तो soya beans हैं, soya chunks हैं, soya milks हम दे सकते हैं. Mostly उसके पनीर होते हैं जिसे tofu कहा जाता है. तो उन सब चीजों को अगर हम डाइट में दें तो प्रिवेंट हो सकते हैं. नेक्स्ट न्यूट्रिशन केयर इन कैंसर. सो सॉफ्ट डाइट इफ चीविंग इज प्रॉब्लम. फॉर एग्जांपल ओट्स है, नॉर्मली अपनी इडलीज हो गई हैं, पोहा है, उपमा है जो सॉफ्ट डाइट्स. लोअर एसिडिटी डाइट फॉर डायरियाज. High protein, high calories, and plenty of fruits undergoing radiation and chemotherapy. No herbals, and avoid mostly dehydrated foods like tea, coffee, and alcohol. 45 to 50 calories per kg of body weight a day. Carbohydrate and fat needed to provide energy and spare protein for tissue building the immune system. 1 to 1.2 grams of protein kg of body weight per day can give an cancer patient. Malnourished client may be needed to 1.3 to 2 grams of per kg of body weight. Vitamins and minerals are also essential. Next. So encourage foods that will increase appetite, because already appetite low होने के कारण और taste नहीं होते हैं, तो like हम try करें कि जो खाना है वो tasteless और थोड़ा दिखने में भी अच्छा रहे, तो mostly वो food brought from home, vegetable soup, आमचूर पाउडर, जब अगर फ्रूट्स खा रहे हैं थोड़ा सा उसमें हम आमचूर पाउडर वगैरह ऐड कर दें तो जिससे उनका सलिवा प्रोडक्शन हो सकता है, एपेटाइट बढ़ सकता है. सिट्रस फ्रूट्स हम दें जिससे सेलुलर प्रोडक्शन थोड़ा और एक्स्ट्रा होगा. फूड में भी मिल्क, एग, फिश एंड सैलेड्स थोड़ा ड्रेसिंग फॉर्म में जाए. और न्यूट्रिशन सपोर्टेड में बी नीडेड, फॉर एग्जांपल प्रोटीन सप्लीमेंट्स, ओमेगा 3 फैटी एसिड्स. नेक्स्ट. So conclusion, cancer is a disease characterized by abnormal cells growth, energy need increase because of hypermetabolic state and tumor need for more energy nutrient. Surgeries, radiation and chemotherapy causes side effects that affect nutrition. Improving the nutrition state, difficulty of illness and anorexia. The parenteral nutrition and enteral nutrition may be necessary for patient not able to take by mouth. The health can professional can help the client improve the nutrition. Next. Next. Thank you so much.
Thanks, Sonam. Sonam, just wait. I would request Dr. M.T. Khan to please come on the stage and please do the honors for us. A man of your eminence cannot be just sitting, sir. Please, please. Sonam, please accept. We have with us Dr. Ajay Digrajkar, a renowned MD medicine and a very well-known. Sir, wait, sir. I would request him to please come on the stage to please, on behalf of Help Your Foundation, we would like to felicitate you. A very well-known name in Bandra, very towering personality, Dr. Ajay. Thank you, Dr. Ajay. Sir, we have Dr. Prashant Joshi with us. Dr. Prashant Joshi, please come. Again, a very popular physician. Sir, please. नहीं, sir, आप बताइए. Of you. We have many dignitaries with us. Thank you, sir. Empty, sir. We have many dignitaries and we'll be felicitating them also. Now we have one of the the best medical oncologists in Bombay, has been worked with Dr. Advani for a long time. Looks very young. He is very deceptive. There's a lot of experience he has and has been doing wonderful. Just let me give you one incident. After I left Tata, we have working with Dr. Khalid in Sai and Dr. Abid in and we did a chemo for that lady, and after 5 cycles the Ashwin Singla to you. Sir, welcome. Please come here.
So, thank you very much. जाफरी सर ने जो तारीफ़ की है वो उस तारीफ़ के काबिल तो मैं नहीं हूँ, बट आई एम कभी कभी कैंसर को हम समझ नहीं पाते हैं. कैंसर इज़ नॉट कि ये कैंसर हो गया इसका कोई सोल्यूशन नहीं है. आजकल ऐसा टाइम नहीं है. सो हर कैंसर अलग है, हर पेशेंट अलग है. जिस पेशेंट की सर बात कर रहे हैं वो पेशेंट ही वॉज अ पेशेंट ऑफ लिम्फोमा, और लोगों ने उसको गिव अप कर दिया था कि पेट में पूरा शरीर फैला हुआ है, बीमारी फैली हुई है. वी डिड अ बायोप्सी, लिम्फोमा था, क्योरेबल है, 6 साइकिल्स कीमो दिया, पेशेंट क्योर हो गया. सो परसेप्शन कैंसर के लिए कैसे चेंज होता है? वो चेंज होता है जब ट्रीटिंग पर्सन का परसेप्शन उसके लिए डिफरेंट हो. मतलब कभी कभी हम कैंसर को अप्रोच करते हैं कि इसमें तो कुछ हो ही नहीं सकता है, तो वो पेशेंट का जेन्युइनली कुछ नहीं हो सकता. अगर हम अपनी तरफ से ही अप्रोच करें कि एक पेशेंट को कुछ भी हो जाए मैं इसको ठीक करके ही छोड़ूंगा, तो किसी भी स्टेज में वो पेशेंट बहुत अच्छा करता है. तो हम लोग एसोसिएशन विद बेंज हॉस्पिटल एंड थैंकफुल टू बोथ द ब्रदर्स, सर ने हमें मौका दिया काम करने का. हम लोग उसी जज्बे के साथ आगे बढ़ते हैं कि कुछ ना कुछ तो करके ही रहेंगे. पेशेंट को इससे बेटर हो जाएगा कि वी विल मेक श्योर दैट द पेशेंट विल बी एटलीस्ट बेटर. कैन वी हैव माई स्लाइड्स? आज मैं बहुत बेसिक बात करने वाला हूँ. 90% पेशेंट्स मुझसे पूछते हैं कि कैंसर होता क्यों है. सो आज मुझे ऑन्कोलॉजी में प्रैक्टिस करते हुए 10 से 12 साल हो गए, 12 ईयर्स. एंड इसमें मैं सिर्फ एक ही चीज़ समझ पाया हूँ, कैंसर क्यों होता है. कैन यू गो टू द नेक्स्ट स्लाइड? कैंसर क्यों होता है? बिकॉज देयर इज एन इम्बैलेंस इन आवर सिस्टम. इफ़ यू लुक एट आवर एंसेस्टर्स, उनका लाइफस्टाइल क्या था? खाना खाते थे, एक्सरसाइज के लिए बहुत काम करना पड़ता था, सेडेंटरी लाइफस्टाइल नहीं था, और एक न्यूट्रिशियस फूड जो कि नेचर ने बनाया है विच इज़ बैलेंस इन कैलोरीज, वो लेते थे. इफ़ यू लुक एट आवर सेल्व्स, हम लोग क्या खाते हैं? वी टेक ऑल प्रोसेस्ड फूड फ्रॉम शुगर टू मिठाई टू चॉकलेट टू केक्स, पेस्ट्री, पिज्ज़ा, बर्गर. जब हम फूड को प्रोसेस करते हैं तो उसमें दो नुकसान होते हैं, जैसे कि सारे के सारे एंटीऑक्सीडेंट्स. सेकेंड नुकसान क्या होता है? वी मेक इट कैलोरी. एक तरफ कैलोरीज बहुत सारी हैं, काम हमने कम कर दिया है, तो बॉडी ऑर्गन्स क्या करेंगे? दे विल ट्राई टू मैच दैट. वो अपना नंबर बढ़ाएंगे, वो नंबर बढ़ेगा एंड दैट विल बिकम कैंसर. सो लॉट ऑफ पेशेंट्स दे आस्क मी कि सर इसका कारण क्या है? द ओनली रीजन इज लैक ऑफ एक्सरसाइज, लैक ऑफ स्लीप एंड हाई कैलोरी इंटेक डाइट. अगर हम ये 3 चीज़ें करेक्ट कर लें तो वी कैन डिफीट एटलीस्ट 50% ऑफ कैंसर. सेकेंड मोस्ट कॉमन कॉज है कैंसर का टबैको. आप विश्वास नहीं करेंगे कि इंडिया ही ऐसी कंट्री है जहाँ पे ओरल टबैको मिलता है. यू नो, इंडिया, बांग्लादेश 2 कंट्रीज हैं जहाँ पे ओरल टबैको मिलता है. ऑल ओवर वर्ल्ड च्यूएबल टबैको अलाउड ही नहीं है. क्यों? मतलब देयर मस्ट बी सम रीजन. रीजन ये है कि इट इज अ श्योर शॉर्ट रीजन फॉर गेटिंग कैंसर. पेशेंट मुझे आके एक चीज बोलते हैं कि सर हम छोड़े कैसे? आई कैन नॉट लीव इट. हम कैसे ये टबैको छोड़े? वी आर सो यूज्ड टू इट. मैं उनको बोलता हूँ कि जब कैंसर हो जाता है तो नेक्स्ट डे से कोई नहीं खा पाता है. इट्स अ मैटर ऑफ फियर. जब आपको डर ही नहीं लगता है तो आप सोचते हैं कि नहीं छूटेगा. जब आप डरेंगे तो अपने आप छूट जाएगा. डरने पे तो सब कुछ छूट जाता है. सो आई थिंक ये सबसे बड़ा प्रॉब्लम है कि लोग डरते नहीं हैं, लोग चीज़ों को सीरियसली नहीं लेते. नेक्स्ट प्रॉब्लम जो मैं आजकल देखता हूँ कि लोग अपनी हेल्थ को लेकर सीरियस नहीं है बिल्कुल भी. यू नो, आज मैं उनको बोलता हूँ कि एक अल्ट्रासाउंड करा लो, मुझे कुछ गड़बड़ लग रही है, सर अभी थोड़ा सा ही पेन है, नेक्स्ट वीक कराऊंगा. फिर वो नेक्स्ट वीक का 1 महीना हो जाता है एंड देन दे कम बैक टू मी कि सर इतना एडवांस कैसे हो गया कैंसर? मेरे को तो कोई सिम्टम ही नहीं था, अभी आप बोल रहे हो स्टेज 4 में चला गया कैंसर. तो फिर मैं उनको समझाता हूँ कि अगर आप पीछे मुड़ के देखें, यू हैव इग्नोर्ड दिस डिजीज फॉर अ लॉन्ग टाइम. आपको पेन था, आपने वो इग्नोर किया. आपका खाने पे इंटरेस्ट खत्म हो गया था, आपने वो इग्नोर किया. आपका वेट लॉस हो रहा था, आपने वो इग्नोर किया. धीरे 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 करके अगर आप मुझसे पूछे तो आपकी कहानी लिखनी शुरू हो गई थी आज से 10 साल पहले, और ये उसका फाइनल चैप्टर है जब आप मेरे पास आएगा. सो पीपल हैव बिकम इग्नोरेंट. वर्ल्ड हेल्थ ऑर्गेनाइजेशन क्या बोलती है? नेक्स्ट स्लाइड करो. वर्ल्ड हेल्थ ऑर्गेनाइजेशन बोलती है कि अगर हम 2 घंटे एक्सरसाइज करें पर वीक, 2 आवर्स, हमारा कैंसर इंसिडेंस 30% कम हो जाएगा. क्यों? क्योंकि बॉडी में इतना सारा पॉजिटिव मेटाबॉलिज्म वाले हार्मोन्स निकलेंगे कि वी विल बी एबल टू बिकम फ्री ऑफ कैंसर. मुझे दो तरह के लोग मिलते हैं, एंड दिस इज वेरी इंटरेस्टिंग, यू मस्ट अंडरस्टैंड दिस। नेक्स्ट स्लाइड कर दो। दो तरह के लोग मिलते हैं। एक तरह के लोग बोलते हैं कि सर कैंसर है ही नहीं, आप बात ऐसे ही करते हो हमें, इतना कैंसर कुछ है नहीं, मैं मेरे घर में कोई कैंसर नहीं है, सब ठीक है। दूसरी तरह के लोग मिलते हैं कि सर सब जगह मुझे कैंसर ही दिख रहा है, मेरे घर में कैंसर है, मेरी सोसाइटी में 5 लोगों को कैंसर है, मेरे फ्रेंड्स में उसको कैंसर हो गया, उसकी फैमिली में 3-4 लोगों को कैंसर हो गया। ये दोनों लोगों में लोग एक चीज भूल जाते हैं कि फैक्ट्स क्या हैं। तो मैं आज आपको फैक्ट्स बताता हूँ। इंडिया के अंदर वी आर डायग्नोजिंग क्लोज टू 14 लाख पीपल विद कैंसर एवरी ईयर, बट ये नंबर पिरामिड का टिप है। इफ यू लुक एट द रियल नंबर्स, द नंबर्स आर एटलीस्ट 5 टाइम्स हायर। वर्ल्ड हेल्थ ऑर्गेनाइजेशन ये बोलता है कि इफ इंडियंस डोंट improve the lifestyle that they are living, 1 out of 3 Indians will have cancer in lifetime. आपको पता है अमेरिका में कितने लोगों की डेथ कैंसर से होती है? अमेरिका में 1 out of 4 people die of cancer. क्यों? क्योंकि आपने डायबिटीज ठीक कर लिया, आपने हार्ट ठीक कर लिया, आपने किडनी ट्रांसप्लांट कर दी, अब आप हार्ट ट्रांसप्लांट भी कर रहे हो, लंग ट्रांसप्लांट भी कर रहे हो। इंसान की लाइफ कैसे जाएगी? कैंसर की वजह से जाएगी। So the cancer incidence is increasing like anything. मैं चैलेंज कर सकता हूँ, यहाँ पे कोई भी इंसान हाथ खड़ा कर दे जिसके रिलेटिव को या उसके फ्रेंड को या उसके फ्रेंड के किसी रिलेटिव को कैंसर नहीं हुआ। इट्स शॉकिंग, कोई नहीं, सब के सब किसी ना किसी को हमें कैंसर है, हमारी अपनी रीजंस की वजह से। सो विद दिस आई वांट टू गिव दिस मैसेज टू एवरीवन कि बिकम सीरियस बिफोर कैंसर गेट्स यू, स्टार्ट एक्सरसाइजिंग, हैव न्यूट्रिशियस फूड, कैंसर स्क्रीनिंग प्रोग्राम्स अवेलेबल हैं। कैंसर का सबसे कॉमन कारण है मोटापा। लेडीज के अंदर, मुझे लेडीज पूछती है ब्रेस्ट कैंसर, तो लेडीज के अंदर लोग मुझे पूछते हैं कि ब्रेस्ट कैंसर बॉम्बे में इतना क्यों फैल रहा है? भाई कैंसर फैलता नहीं है ऐसे, आपको देखा मुझे हो गया, मुझे देखा आपको हो गया। अगर हम डेटा की बात करें, एंड दिस इज वेरी गुड, अपने स्टूडेंट्स के लिए भी ये मैसेज कि बारसी एक विलेज है, वहाँ पे कोई भी गवर्नमेंट को कोई स्टडी करनी होती है वो बारसी विलेज जाके करती है, ठीक है। वहां पे एवरी 64 वुमेन में एक को ब्रेस्ट कैंसर है, एवरी 64 वुमेन में एक को। अगर हम बॉम्बे आ जाए, बॉम्बे में 16 में से एक वुमेन को ब्रेस्ट कैंसर है, और हम अमेरिका चले जाएं तो अमेरिका में 8 में से एक लेडी को ब्रेस्ट कैंसर है। तो ये क्यों हो रहा है? अगर आप बारसी की सारी पॉपुलेशन उठा के बॉम्बे कर दो तो फिर उसका इंसिडेंस वही हो जाएगा 1:16, और सबको अमेरिका ले जाओ तो 1:8 हो जाएगा। इसका रीजन है हमारा लाइफस्टाइल। वी आर, वुमेन इज सपोज टू बी द स्ट्रॉन्गर पर्सन देन मैन एज पर नेचर। उसका काम क्या है कि सारा काम करना, बच्चे पैदा करना और अपने परिवार का ख्याल रखना। आजकल वुमेन का काम क्या है? 1 या 2 बच्चे, एंड देन हाई फूड, न्यूट्रिशियस फूड, लेजी लाइफस्टाइल। मुझे कोई प्रॉब्लम नहीं है इससे, बट इसकी वजह से उनके अंदर ब्रेस्ट कैंसर का इंसिडेंस बहुत ज़्यादा बढ़ रहा है। सो हम इसको कॉम्बैट करने के लिए क्या कर सकते हैं? हर वुमेन को अपना मैमोग्राफी करना चाहिए आफ्टर द एज ऑफ 40 ईयर्स। दे शुड डू सेल्फ एग्जामिनेशन। यूट्यूब पे वीडियोस होते हैं, व्हाइल टेकिंग अ शावर दे शुड एग्जामिन देमसेल्व्स कि भाई अपने आप को एग्जामिन करें, कोई ब्रेस्ट में लंप तो नहीं लग रहा है। एनी एबनॉर्मल चेंज इन शेप ऑफ ब्रेस्ट और लंप, प्लीज़ उनको एक डॉक्टर के पास पहुंचना है, लेडी डॉक्टर को बोलना है या फिर ऑन्कोलॉजिस्ट के पास जाना है। कभी कभी गायनेकोलॉजिस्ट इग्नोर करती हैं, ये प्रेगनेंसी में ऐसा होता है, प्रेगनेंसी के बाद ऐसा होता है, लंपी फीलिंग लगती है ब्रेस्ट में। आई एम टेलिंग यू, बॉम्बे में ब्रेस्ट कैंसर इज वेरी हाई बिकॉज ऑफ आवर लाइफ स्टाइल। प्लीज रीच आउट टू अ डॉक्टर बिकॉज दे कैन चेक। एंड फर्स्ट स्टेज के अंदर ब्रेस्ट कैंसर पूरा क्योरेबल है, नो नीड फॉर कीमोथेरेपी। आजकल हमने कीमोथेरेपी भी बहुत सारे कैंसर्स में देना बंद कर दिया है, अगले 10 सालों में पूरी तरह बंद हो जाएगा। आजकल एरा है टारगेटेड ट्रीटमेंट का। सो मोस्ट इंपॉर्टेंट थिंग इन कैंसर इज, the last 2 minutes of my talk is diagnose cancer early, treat cancer early, screen for cancer and use the correct treatment for cancer. ये चारों तभी हो सकते हैं जब आप सतर्क रहें और इससे लड़ने को तैयार हैं। थैंक यू सो मच।
Thank you very much, Dr. Chingla. Dr. Shfaq, please come up on the stage. Professor, please come on the stage. I'm sorry, we are all now doctors here, so it becomes a little habit to talk about doctor. I would request Dr. Shivam to. We have Dr. Mahesh Hakke, endocrinologist with us. Please come on the stage. Leading practitioners. We have with us Mrs. Ritika Rohit, an executive finance manager from JJ Foundation. She is also chairman of the PVM Gymkhana. Please come on the stage. We have Dr. Akhtar Sheikh with us. He is the Dharavi Medical Association President and Secretary. I would request MD Cancer to join, please. Please join me. Thank you very much. Thank you, Dr. Swag. Now we have one of the leading cancer surgeons, oncosurgeon as we fondly call them, was a dynamic surgeon at Tata Hospital. After that, he has now been practicing all over India and has a very roaring practice in India, Bombay. Very happy that he is now associated with us. As all the people who are sitting here may know that after my retirement, and as I said about this hospital, all of you are now getting the best of the cancer surgeons from ex-Tata to deal with your patients at these hospitals at a very affordable cost. So he is again one of the luminaries which we were trying for a long time, and now he is with us. So I would request him to first give his presentation and then we'll take this program further.
Thank you, Javri Saab. I'm sorry I'm a little late because of the traffic. First of all, I'll thank the organizers to give me an opportunity, including our hospital directors, Dr. Abid, Dr. Shahid, and all the members involved. It's a very nice audience, patiently listening to Saturday afternoon. So I would make it little brief. I would be talking on robotic surgery. My slides, please. I'll just give you a brief overview because detailed analysis and presentation regarding robotic surgery is beyond the purview because of paucity of time. I am Dr. Tanveer Majid. Next slide, please. I have been actually trained at Tata Memorial Hospital in Mumbai and then subsequently did thoracic fellowship and then HPB and living transplant in Singapore. These are the credentials for the last 3 years which I have got. One of the most trusted oncosurgeon award. Then I am featured. Next slide, please. Robotics systems, one of is Da Vinci, which is a gold standard, but recently some other systems have been come up. So I'm working on a Da Vinci system, on a Vercius system now. Next slide, please. Surgical robotics was actually introduced in the year 1987 initially. And the first robotic surgery which was performed was a robotic cholecystectomy, like laparoscopic cholecystectomy. And over time there has been evolution by integrated surgical systems and other systems, and at present in the year 1993 this FDA approved robotic surgery, and a year about 2000 the Da Vinci came up with one of the most advanced robotic system in the country, in the world rather, and a lot of institutes have been actually using Da Vinci. There are various advantages and disadvantages. we limit ourselves to only advantages of robotic surgery. Next slide, please. Next slide, please. This is a Da Vinci system that a surgeon is sitting in a console, and this is the patient side, the anesthesiologist is starting, and that's the robotic system with 5 arms. Normally, this looks like what is happening in a robotic system. The surgeon can always move away, relax, go midway, have a cup of coffee, and then come and start operating again. So there is elimination of fatigue in these robotic systems. Next slide, please. Now, what are the advantages of doing robotic surgery? Robotic surgery is exact replica of open surgery. Alright. Like laparoscopic surgery, you have only 3 arm movements. Whereas in robotic, like in open surgery, you have 7 degrees of movement. The first line, even 7 degrees. One important thing is over time when people age, your hand starts shaking and tremors. So that tremor can be, in an open surgery, the tremors will reflect into your surgery. Whereas in robotic system, this is eliminated. So very important is you can eliminate tremors in a robotic system. Then motion scaling and all those things are there. The only limitation of robotic surgery, it is costly. Unless and until lot of robots come with a very minimal cost, this does not transform for all patients, because most of the patients, if they need robotic surgery, it is really expensive. So new companies have come up with various systems, and we are trying to cut the cost of the robotic surgery. Next slide, please. Now, most important thing, this is a hand. Alright. In laparoscopy, you have 3 arm movements, whereas in robotic, you can see, you can have flexion and extension in the wrist joint. You can have adduction and abduction at the torso, at the carpo-metacarpopharyngeal joint. And then you have grasping effects. So these are the advantages. So a robot arm actually replaces a human arm. So that's why it actually reflects as if you're doing an open surgery. Next slide, please. This is the same thing. See, 7 arm movements and 3 arm movements. Second thing, when you're doing laparoscopy, it is 2D, 2-dimensional. So you cannot perceive the depth. Whereas in robotic surgery, it is 3D. So you can perceive the depth also. So that is one important thing. So based on all this, a lot of surgeons have started moving because it is less tiring. The efficiency is very good. Your resection is very good. The post-operative outcome of these patients is very good. So everyone is shifting to robotics. Next slide, please. Now, whenever we are doing an oncology surgery, these are the 4 basic principles. It should be a radical procedure. You should be able to isolate the vascular pedicle, because that is where all the lymphatic drainage comes. So you are able to isolate the vascular isolation. You should have an adequate margins of clearance, and this all should be coupled with a radical lymphadenectomy. Now when I am doing a laparoscopic pelvic node dissection, I am seeing 2 arms. So it could be possible that the adequacy of my resection would be, say, about 92 to 93%. Whereas if you same thing robotic, it becomes 95% more. So you are able to do a better lymphadenectomy with a robotic procedure. Next slide, please. This is a slide which I got. What it says, macroscopic complete resection rates. Robotic surgery, it's above 95%. So whatever is visible to you, a person is able to remove. Recently, there is an article which is there, and the people asking opinions, the surgeons, robotic peritonectomy with HIPEC. That's so it is evolving. People are trying to actually push more and more robotic surgery for its various advantages. Next slide, please. This is the slide. Next slide, please. Next slide, please go ahead. This is actually role of minimally invasive surgery. This I had made a slide. Next slide, please. Next slide, please. Next slide, please. These are all the surgeries, lung, chest wall resections, ultra low resections. Next slide, please. Now, people are doing a lot of robotic surgery, but for the beginner, the best thing is organ which are fixed, like prostate gland fixed, kidney it is fixed, esophagus it is fixed. So in those patients doing robotic surgery, thymus also it is fixed. It is advantageous. Whereas as you evolve over time, then you actually go for organ which are mobile, like gastrectomies and colectomies, and there are so much advances that people all over the world are doing robotic hepatic resections also. So it is developing all over. Next slide, please. Now you imagine this is a patient whom I am going to operate on a lung cancer. This is what I give in open surgery. Next slide, please. Next slide, you can press. See, that's the lung resection I have done. That's the lower lobe. That's the heart beating with a phrenic nerve. This is the descending thoracic aorta, pulmonary artery. Next slide, please. Now, when you're doing robotic surgery, the things, it is small. You can see the incisions are very small. They are some 4 or 5, 10 millimeters incisions. And because these organs are fixed, you can actually selectively resect them, and you can always have an as good clearance as you get in open surgery. Next slide, please. It is so easy. You take from 10 port, you retract these lungs down, isolate the vascular pedicles, and resect and staple them across. Next slide, please. This is another, see, that's the superior pulmonary vein. The red one is the superior pulmonary vein, which you are stapling with a robotic arm. So this all becomes technically easier. See, still gold standard is open surgery, but you can always convert to open. There is no problem. If there is a catastrophe, there is a problem, you can always convert to open surgery. But it is always better. There is a problem only related to cost, which over a time lot of companies are coming up. This Versus system also has come up, which is much cheaper than the actually traditional Da Vinci system. Next slide, please. Next slide, please. That's now why we go into robotic surgery or minimally invasive surgery. Well, actually analyzed subject, we have seen that people who undergo minimally invasive or robotic surgery, the ventilation after lung thoracic surgery, the days of requirement of ventilation is much less. There are less complications. These patients go home earlier, and plus cosmesis, there is less pain in them. So when there is less pain, they are able to cough well, there is no lung infection and things like that, which is very common with open surgeries. So it is a well proved in an analysis which is a randomized controlled trials, and this is a basically meta-analysis. So it's a very scientific data. So minimally invasive surgery for thorax is to stay. Next slide, please. This is the system which we have in our hospital. One of the hospital which I go, this is a Versus system. I am doing a robotic abdominoperineal resection. So, next slide, please. Next slide, please. This is, I am taking the inferior mesenteric artery. You can see I am sitting on a console. Those left hand side corner is the instrument which I have kept it open, and the one which I am using is closed, it is not shown. So we are doing a robotic abdominoperineal resection for this patient. Next slide, please. Now, no, previous slide, please. Don't start the slide. Now, whenever you do robotic surgery or minimally invasive surgery, you can actually see what you are doing. All right. Now, open surgery, if you're doing in the pelvis, everything is not visible. You have done a stapler, you do a leak test, you feel there is a leak. The air is coming out. So, you put in a divergent stoma for that patient. But in robotic surgery, you can actually see. Next slide, please. This is an innovative method where you give ICG dye. And if you're doing robotic, you can actually see the area of the anastomosis, whether the blood supply is good or not. So that's a very important thing which you need to see. Otherwise, you end up devascularized anastomosis, which is surely going to leak. So this is another advantage, that you can predict the outcome of your surgery if you are doing minimally invasive or robotic surgery. See, see, everything is vascular and green. The perfusion at both the ends. So this is not going to leak. If one of those would have been dark, it would have definitely leaked. So you can make out the actually arborization of the vessels if you're doing this minimally invasive robotic surgery. Next slide, please. You can see for anastomotic issues also. When you're doing an anastomosis, you may have a leak. Next slide, please. See, can you see that? It is not perfused like the previous one. So this you have to go down and revise the anastomosis. Next slide, please. Now another important thing is when you do a prostate surgery. Prostate surgery, actually prostate is a gland which is closely related to the urinary bladder, closely related to erection mechanism. Now open surgery, the minimum incontinent rate and is about 15%, and about 10 to 12% have impotency rates. That is because the neurovascular bundle gets damaged. But when you're doing a minimally, because of the high magnification and very precise dissection, you can actually lateralize the neurovascular bundle and then do a prosthetic. So this was actually the first surgery which people had advocated. So this is developed very well, and now any surgery prostate means it is robotic prostatectomy because of its various advantages. Next slide, please. Now can you see, this is a table. The last side, 100 patients have been analyzed. Reasonable operative time, less than 100 ml of blood loss. Cancer remaining is only 5%, whereas 25% for the others. 5% complication. 3 to 5 days is only the catheter stays, and hospital stay of 1.2 days. You can imagine, compared for open prostatectomy. So this all cuts down the cost, cuts down the morbidity, actually hastens recovery. Next slide, please. This is again improved continency rate with this. Next slide, please. Less chance of impotency and erectile dysfunction. Next slide, please. Now, this is the inference that actually minimally invasive robotic surgery is there to stay. It is advantageous over conventional open surgery. For the reasons I have told you, it has got a better short-term outcomes, similar long-term outcomes, better magnification and vision, advantages of nerve preserving, that is for robotic surgeries, prostate surgery and esophageal surgery, where you dissect with the recurrent nerve. It's very important, and it is thought to be expensive, but with newer robotic system which has come up, I think over a period of time it will be almost on par, or maybe 15 to 20% more costly than an open surgery, but earlier delay, earlier recovery, less ICU stay and earlier discharge will all compensate. So robotic surgery is here to stay, and I am sure most of you would have been aware of robotic surgery. And with this I end my talk. If you have questions, I can take it. Thank you so much. Thank you so much.
I'll request Dr. Jafri to felicitate our guest, Mr. Jishan Siddiqui. Beta, please. Sir, you do it. No? We will come, we'll come. Sir, you do it, sir, please.
This photo is for the college. Please, all others can just sit down, please. This is for the college. Hello. Zeshan Bhai, I would like you to please do some honors. Please come on the stage. And first of all, I would request Dr. Majid Tanveer to please receive your Dr. Arshad Jamal, Dr. Wagmare sir, please come. Dr. Amjad, please come. Dr. Mohram Ali, President of the Dr. Asif Chaudhary, lecturer from TBI College. Dr. Tausif. Dr. Arshad Jamal, you can first receive your. Dr. Tausif. Dr. Safdar. We have Dr. Mazhar, nephrologist amongst us. Dr. Mazhar may also please come up. Dr. Mehta Farooqi, please come. Dr. Mazhar, please accept your felicitation. Before we go further for this program, I would request Dr. Khalid to say a few words, followed by Dr. Abid, and then we will have the chief guest speaking.
गुड आफ्टरनून. स्टेज पे जिशान भाई, जाफरी सर, डॉक्टर वसीम एंड डॉक्टर तनवीर और बाकी सब मेरे दोस्त, रचना मैडम, सबसे थैंक्स रिजवी कॉलेज का, रुबीना मैडम का, अख्तर सर का, इतना अच्छा प्रीमाइसेस दिया, इतना कुछ अरेंजमेंट किया. ये 6 दिन का प्रोग्राम कैंसर पेशेंट को स्क्रीनिंग किया गया. उसमें जो भी पेशेंट पॉजिटिव आएंगे उनका फ्री ट्रीटमेंट करेंगे. ये हेल्थ सेल्फ फाउंडेशन और साई हॉस्पिटल मिलकर साथ में काम करेगा. कोऑर्डिनेशन की बात, जितने भी डॉक्टर्स हैं, अगर इनको हम सब डॉक्टर्स अगर हम ढूंढना चाहें तो बड़ी मुश्किल से लोग मिलते हैं, लेकिन कम से कम मैं इतना कह सकता हूं कि आप में से किसी को भी कभी भी कोई भी ज़रूरत होगी, आप हेल्थ सेल्फ फाउंडेशन को कोऑर्डिनेट करें, अलकम्मा सर को करें, रुबीना मैडम को करें, और उसके थ्रू साई हॉस्पिटल मिलके इनके साथ, और हम लोगों के पास जितने भी यहाँ पेशेंट्स पॉजिटिव आए हैं, जिशान भी, सभी पेशेंट का ट्रीटमेंट फ्री होगा. पूरा पेशेंट से 1 रुपया नहीं लेंगे, और उसके लिए पूरी टीम हमारी है. जाफरी सर ने इतना अच्छा टाइम दिया, सब लोगों ने मिलके एक दूसरे को सपोर्ट किया. अर्चना मैडम 22 साल से कैंसर पे काम, रितिका मैडम है. अब हम इसकी वजह से इस प्रोग्राम से क्या हुआ, हम लोगों की एक अच्छी टीम बन गई है. जैसे वसीम भाई है, देखिए ये डॉक्टर वसीम है, इनको कम से कम मैंने 200 फ्री पेशेंट भेजा है, और 200 को इन्होंने फ्री में किया है. मतलब आज ये जितने लोग हैं ना, इन पेशेंट इनके यहाँ भेज दो, पेशेंट के पैसे अरेंजमेंट सब कुछ ये कर लेते हैं. सी क्या है, एक आदमी इनिशिएट करता है ना तो उसके साथ टीम जुड़ जाती है. आज अपनी टीम इनिशिएट आप करोगे, आप हमको बोलोगे पेशेंट गरीब है, उसको रिसोर्स मोबिलाइज करना, उसको पैसे लाना, उसका ट्रीटमेंट करने का काम हमारा है. ये सब कुछ मिलके हम सब लोग साथ में मिलके काम करेंगे, और यहाँ से जो कुछ भी हो सकता है मैक्सिमम महाराष्ट्र के किसी भी एरिया का, इंडिया का कहीं का पेशेंट रहेगा उसको फ्री में ट्रीट करेंगे. थैंक यू वेरी मच.
We have with us Dr. Palak, our ENT surgeon. Please come on the stage. Dr. Palak. Here she is. Oh. Dr. Zizan, please do the honors for us. Archana madam will please do the honors. Archana ma'am has been very instrumental in making this program a very big success. She is one of those people who is not only an model, artist, program organizer, medical conferences, but also she is working on a hospital for a free treatment for cancer patients at Shirdi. A very big job she is doing. I hope all the best of luck for her in her venture. I would request Mrs. Ihsan to do me one honor. Archana ji, you please be there. Let us. She is part of our organizer system, but still she has done a lot of work. Dr. Khalid, you may also please come up on the stage and we may give a shawl to him. We have from Ben's two of the directors. We would request first Dr. Shahid to please accept his bouquet. Dr. Shahid, अभी तक तो आप स्टेज पे थे. And we have also Dr. Abid. Dr. Abid, please collect your shawl and then say a few words.
No, before that, you'd like to add a
You do that? Achha.
Jai Hind, Namaste, good evening to everybody, honorable dignitaries on the dais and entire team of Rizvi College. I express my sincere gratitude to each one of you for being here today and making this event a successful event. I'm truly thankful to my chief guest, Jishan Siddiqui ji, and I'm so proud to announce that he grew in front of me, and today he has made himself proud, not only to himself but to his parents and to all the Bandroites that we know him as a young, dashing leader. Thank you so much, Jishan ji, for accepting the invite. There's a team which works behind the success. The lady of substance, none other than Advocate Rubina Akhtar ji. Let's give her a big round of applause to the lady. And to the heart of this institution, Akhtar Sahab, the president of Rizvi College, Dr. Akhtar Rizvi. May we all stand up to give them a big round of applause for what they have created today, the magic of screening 2,000 women in the 6 days camp, and they detected a lot of women who have not known that they were having cancer, but due to their efforts, what the Rizvi organization, Help Yourself Foundation has done today of saving women, because we believe woman is a creator of the universe and woman needs to be respected and treated with respect and dignity. Today, my heartfelt gratitude goes out to Advocate Rubina Akhtar ji, who we should have maintained the protocol of inviting the lady on time. Because I believe in medical, if we are not treated in time, we do not get cured. So prevention is better than cure, but valuable of time is also very important. When we have the two pillars of this camp, Dr. Akhtar Rizvi Saab, Advocate Rubina ma'am, who have created this platform to make India cancer-free India. I truly miss their absence, and I pray in future we maintain the protocols where we invite the most important dignitaries, the backbone of this breast cancer, and we honor them in front of each one of you for doing this spectacular event, which would have not been possible without the efforts of President Dr. Akhtar Saab and also without Rubina Akhtar ma'am. So big round of applause for both the pillars of this camp. I would also like to thank the backstage team who have been on their feet 24 hours. Dr. Alkama sir, may I have you on the screen? The designs you are seeing is done by Wasim sir. He specially flown from Karnataka to design our presentations today. Thank you, sir. Thank you so much, our honorable chief guest, for doing these honors. I would like to thank one and everybody present here who has taken a valuable time out to hear us, to be a blessing to the society. Because हमने भगवान तो नहीं देखे हैं, लेकिन जब हम डॉक्टर की जरूरत करते हैं, हम उसे भगवान मानते हैं. And I always believe doctor cures diseases, but he is a healer of humanity. Thank you so much, Dr. Saab. We respect you. We have high regards for you. And let us pledge today that we will unite to fight cancer and make India the first country to be the role model for other countries where we can proudly say, yes, India is cancer-free today. I'm coming up with a 500 cancer bed hospital in Shirdi, free of cost for entire nation of this country, where anybody, caste, creed, religion will not be considered. You will be treated as an Indian, as an Bharatiya. Okay, this medicine which you will be treated in Saidam Hospital will be free for everybody. So join this mission of 500 cancer-free hospital and let us unite and say, Mera Bharat कर्क मुक्त भारत है. जय हिंद, जय महाराष्ट्र. Thank you very much. Thank you.
I would like Dr. Abid to say a few words before we ask the chief guest to summarize.
स्टेज पर बैठे हुए चीफ गेस्ट जिशान सिद्दीकी साहब, डॉक्टर खालिद, डॉक्टर अमजद, डॉक्टर वाघमारे, अर्चना मैडम और जाफरी सर, वसीम पॉपुलर सर और डॉक्टर तनवीर माजिद और सब मेरे बाकी फ्रेंड्स, बहुत बहुत आप लोगों का शुक्रिया कि आप लोग यहाँ आए. डॉक्टर रुबीना और अख्तर रिजवी साहब ने जो ये इनिशिएट शुरू किया है, ये लोगों में बहुत ज़रूरी है कि लोग अवेयर हों कि कैंसर को कैसे लोगों को पता चले कि अर्ली स्टेज में कैसे होता है. हम लोग क्या होता है कि छोटी सी गांठ होती है, उसको धीरे धीरे बढ़ाते बढ़ाते 3rd स्टेज 4th स्टेज पे कर देते हैं. तो हम लोग इसको अवेयरनेस प्रोग्राम शुरू करेंगे और इन्होंने बहुत बड़ा वो किया है कि लोगों को इससे आगाह किया और इससे लोगों को भी वो मिलता है कि लोग इस चीज़ को शुरू करें और इसका इलाज जल्द से जल्द शुरू करें. थैंक यू.
इस कैंप को सबसे ज़्यादा जिसने सपोर्ट किया है वो जाफरी सर है. सबका हो गया, इन्हीं का प्ले स्टेशन नहीं हुआ. सर प्लीज़. हाँ सर, जिशान भाई, डॉक्टर जाफरी साहब का प्लीज़. सर ने बहुत मेहनत की, सबको जोड़ने का काम इन्होंने किया है. ये सब अलग अलग करी थी लेकिन सबको साथ में लाने का काम इन्होंने किया. जाफरी सर, जिशान भाई, थैंक यू.
थैंक यू डॉक्टर खालिद. वैसे तो हम लोग सब ऑर्गेनाइज़र हैं और हम लोगों का, आप लोगों का आना इस प्रोग्राम को सक्सेसफुल बनाना ही हमारे लिए बहुत बड़ी बात होती है. बट आप जैसे सोचने वाले गम निकते हैं. थैंक यू वेरी मच फॉर दैट. और मैं सिर्फ कुछ बातें हमारे जिशान सिद्दीकी से कहूँगा. मैं बांद्रा का ही रहने वाला हूँ और बांद्रा में ही हम लोग, और मुझे फ़क्र है कि मैं इनके फादर के साथ कॉलेज में था, वो मेरे सीनियर थे और जिन्होंने बहुत बॉम्बे में बहुत बड़ा नाम कमाया और उसके बाद इनकी नेक्स्ट जनरेशन भी आज कर रही है. बहुत अच्छा नाम इन्होंने कमाया है, बहुत अच्छा काम करते हैं और अभी अभी बहुत बड़ा जिम्मेदारी इनके ऊपर है कि पूरी की पूरी नेशनल की जो बड़ी से बड़े लीडर्स आने वाले हैं और उनका सारा अरेंजमेंट इनको करना है. उसके बावजूद, उतनी मशरूफियत के बावजूद उन्होंने टाइम दिया. तो पहले तो थैंक यू वेरी मच सर, आपने इतना अपना टाइम हमारे लिए दिया और मैं चाहूँगा कि 2 शब्द हम सबके लिए आप कहें. थैंक यू वेरी मच.
मैं शुक्रिया अदा करना चाहूँगा डॉक्टर अख्तर रिजवी जी का, एडवोकेट रुबीना अख्तर रिजवी जी का, डॉक्टर आबिद सैयद जी का, डॉक्टर खालिद शेख जी का, डॉक्टर सैयद जाफरी जी का, डॉक्टर शाहिद सैयद जी का, डॉक्टर अर्चना जी का, मेरे भाई वसीम भाई का जिन्होंने मुझे इधर आमंत्रित किया है. और मैं आप सभी को बहुत बहुत बधाई देना चाहूँगा कि एक बहुत ही बेहतरीन कैंसर डिटेक्शन का एक ड्राइव हुआ है ये 6 दिन. और आई वुड लाइक टू thank all the doctors that are present in this event with us. It felt great to felicitate so many doctors. That clearly shows that we're in safe hands, and so many doctors under one roof. I'd like to thank each one of you for your time and the efforts that you have put in. Rizvi College Foundation, RumiCare, Saquib Rizvi Memorial, Sai Hospital, Ben's Hospital, and the entire support staff that have made this event possible, made this breast cancer awareness program possible. And I would appreciate if this goes on and we take this locally to people, because we need to spread awareness, as the doctors rightly said, that it's very important for us to find out and detect cancer early so that we can cure it properly. And being a Bandra boy myself, I've always grown up seeing Rizvi College and all the initiatives that Rizvi College has been taking. My father has great relations with Dr. Akhtar Rizvi Saab, and it's a proud moment for me to be on dais and extend my gratitude towards all the doctors and the support staff for this great event. And I'm sure with your guidance and your efforts, we will see such events more. When I was talking to many doctors, they were talking to me about free treatments happening across Mumbai, across Maharashtra, across the country. So such initiatives will really help the society, and I will be more than happy to extend my help